Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover thyroiditis. Okay, so to begin this video, we're going to go through the infection-related ones, acute thyroiditis and subacute granulomatous thyroiditis. And now, in the next sections of the video, we're going to go through Hashimoto, Riedel, and lymphocytic, which are more chronic inflammatory-related conditions. And now let's begin with acute thyroiditis. For the etiology, the most common cause is going to be Staph aureus. This is going to be your most common cause. And if the patient is immunocompromised, you may consider either fungi or parasites. And also a direct trauma to the gland can cause an acute inflammatory reaction. Now these patients are going to present with fever, and this one, a tender gland, is going to be one of the more important signs and symptoms for acute thyroiditis and for subacute granulomatous thyroiditis, okay? So if you review in physical examination the thyroid gland, the patient is going to hate you because it's super painful, okay? Cervical adenopathy may or may not be present, and of course, these patients may develop initial thyrotoxicosis, and this is due to gland destruction, okay? So your thyroid hormones are going to go up, your TSH is going to go down, and the patients may develop into hyperthyroid symptoms, okay? And with these patients, permanent hypothyroidism is usually uncommon. It may develop, but it is not commonly seen, okay? Now for the diagnosis, as we saw, the radioactive iodine uptake is going to be low. So the gland is in an inflammatory state, it is being destroyed, it is not producing hormone, and remember that the thyrotoxicosis that you see initially is because of gland destruction and not because the gland is producing more hormones, okay? Now the treatment, for the pain, you're going to use NSAIDs. If the patient develops thyrotoxicosis, you may beta blockade the patient, and if you suspect Staph aureus, you may add or may not add antibiotics, okay? So for the subacute granulomatous or Deckervine thyroiditis, the etiology is going to vary. For these patients, it is viral infections, the number one cause. Coxsackie virus or mumps are usually related. And it is termed subacute because it's often preceded by an upper respiratory infection. It usually occurs in women with 40 to 50 years of age. And for the signs and symptoms, remember, these patients may or may not have fever, but painful gland is commonly present. These patients do not develop prominent cervical adenopathy, and the same, the initial thyrotoxicosis with gland destruction may be seen, elevated thyroid, low TSH, and also hypothyroidism is uncommon. Okay, now the diagnosis is the same, gland is not working, so the uptake is low. The treatment also NSAIDs for pain, beta blockade if the patient develops hyperthyroid states, okay? Okay, so let's continue with Hashimoto thyroiditis. This one, as we mentioned, is a chronic lymphocytic autoimmune disease. Lymphocytic autoimmune disease, okay? It is the number one cause of primary hypothyroidism and hypothyroidism as a whole. It is usually more seen in women. The HLAs related are DR3 and DR5, okay? It has a higher incidence in these syndromes, Turner, Down, and Klinefelters, and it has a high incidence of other autoimmune diseases, okay? Pernicious anemia, vitiligo, diabetes mellitus type 1, etc. Okay. Okay. So increased risk for primary B cell malignant lymphoma. Okay, in this disorder of the thyroid, and pathogenesis. It is usually related to cytotoxic. These are CD8 positive T cells that destroy the parenchyma, and this is considered a type 4 hypersensitivity reaction. And this these patients may develop initial thyrotoxicosis because of the acute inflammatory state with release of the hormones, and they eventually progress to hypothyroidism, okay? And then there's also CD4 positive T cells related that attract macrophages, and there's also production of antibodies against parenchymal tissues, okay, against parenchyma, which is antimicrosomal. These are the specific ones, anti-thyroperoxidase and anti-thyroglobulin, okay? And this right here is considered a type 2 hypersensitivity reaction, okay? Now for the signs and symptoms, these patients are gonna have a diffuse goiter, which is usually painless, versus the previously seen ones, the acute and subacute, which are pretty painful. These ones are painless, and it is usually palpated as a rubbery gland, okay? Remember, these patients can develop hashitoxicosis, and then they enter hypothyroid state. And now for the diagnosis, it comes in relation to this. You may have normal thyroid hormones or hyperthyroid state with depressed TSH, and eventually they develop the hypothyroid state with increased TSH. And here is where you usually do your diagnosis, right? Remember to check for the specific antibodies. If you have the symptoms, if you have your TSH elevated, and if you test for the other antibodies, you have your Hashimoto diagnosis, okay? And you may not perform the biopsy. I put it here because it's pretty specific to see a lymphocytic infiltrate. This one right here. The germinal centers are specific for Hashimoto disease with destruction of the follicles, and obviously a pretty chronic inflammatory condition for the gland, okay? And for the treatment, as all hypothyroid states, replace levothyroxine, and you may do this gradually to avoid complications, okay? So that's going to be for Hashimoto. Okay, so now let's finish with the last two thyroiditis. The first one being radial thyroiditis. For its etiology, it is a chronic inflammatory disease, and it is characterized by the deposition of fibrous sclerosis in the gland, and particularly it may extend to near tissues such as the trachea or the mediastinum. Particularly the etiology has not been well elucidated, but it is associated with other sclerosing conditions. For the signs and symptoms, hypothyroidism may occur if it develops for long enough, and obstruction of the trachea and the esophagus and mediastinal structures may develop. Now, for the subacute painless lymphocytic thyroiditis, the etiology is usually an autoimmune condition, but it usually occurs in postpartum patients. So we don't know exactly what causes it. It can be related to the pregnancy itself or a viral infection. It is also not well elucidated, but it most commonly occurs in patients after being pregnant. And now for the signs and symptoms, there's an abrupt onset of thyrotoxicosis usually, and this is due to gland destruction, okay? The gland is slightly enlarged, but it is painless. Keep this in mind. And 40 to 50%, almost half of the patients progress to hypothyroidism, okay? So around 50 to 80% of the patients have positive antimicrosomal antibodies, and this may lead you to think that it is in some way very related to Hashimoto, right? But in the biopsy, you will see lymphocytic infiltrate, as with Hashimoto, but this one has no germinal centers, okay? So it is like a Hashimoto, but not well developed in these glands. And now the treatment goes for the beta blockade if the patient develops hyperthyroid state, and these patients, as half of them progress to hypothyroidism, they may need replacement of the hormone, okay? So that's going to be for the thyroiditis. For these conditions, keep in mind, first of all, the etiologies, and mostly the signs and symptoms. Recognize which one is painful, which one is painless, and some diagnostic procedures. And with all of them, if you have an hyperthyroid state, give beta blockade, and if they develop hypothyroidism, replace the hormones.